types of systemic treatment are usually used for early-stage breast cancer: chemotherapy and hormone therapy. They are called adjunctive therapy because they are used in addition to surgery and radiation. Adjunctive means additional. Both chemotherapy and hormone therapy may be given alone, although many women receive both. Adjunctive systemic therapy lowers the chances of breast cancer recurrence by about 40%. To determine how much benefit you will get from adjunctive therapy, you will need to know your percentage chances of the disease coming back. This depends on the prognostic factors that we talked about earlier. The most important factors being the size of your tumor, whether the nodes are involved, if the tumor is hormone receptor positive or negative, and your age. Your doctor will be able to tell you the chance of the breast cancer returning in your particular case. Now, the 40% reduction in chance of the cancer returning is called a proportional reduction. You want to know your absolute reduction. Here is an example. If 100 patients with the same stage of breast cancer have a cure rate of 70% without receiving chemotherapy, this means the cancer will recur in 30 patients. Chemotherapy will cure 40% of those 30 patients. So the absolute reduction is 12%, since chemotherapy is only responsible for curing 12 of the 100 patients. However, if 100 patients with early-stage breast cancer have a cure rate of 90% without receiving chemotherapy, the cancer will return in 10 patients. Chemotherapy will cure 40% of these 10 patients. So the absolute benefit is only 4%, since chemotherapy is responsible for curing only 4 of the 100 patients. It is very important that you understand how much benefit you will get from either chemotherapy or hormone therapy. These treatments have potential side effects, and you have to decide if the benefit in terms of increasing your chances of being cured is worth the side effects.
Adjunctive therapy is almost always recommended for women with early-stage breast cancer, except for some women with very small tumors of less than 0.5 centimeters and with lymph nodes that do not have cancer in them. The type of therapy chosen, which may be either hormonal or chemotherapy, depends on many things, such as the woman's age, the estrogen receptor status of the tumor, the number of positive nodes, as well as her general state of health. Chemotherapy uses drugs to kill cancer cells. It usually begins 4 to 6 weeks after the final surgery, and most often uses a combination of drugs. Chemotherapy drugs can be taken in pill form or injected intravenously. Sometimes a combination of the two is used. Depending on the drugs used, a woman receives chemotherapy once or twice a month for 3 to 6 months. At each visit, an IV is inserted into a vein in the arm, allowing the drugs to drip slowly into the bloodstream. Many women have a device called a portacath inserted under the skin of the chest, which allows access to a major vein in the body. The portacath remains in place for several months and is used to administer the chemotherapy. This technique is a more reliable way to administer chemotherapy, minimizing the number of needle sticks, and can often be used to draw blood if needed for any required laboratory tests. Each chemotherapy visit lasts from 2 to 6 hours. Part of that time may be used to administer hydration fluids. Patients can bring someone with them during the visit. They can also read or watch television during their treatment. There are many different chemotherapy drugs. Several of them are doxorubicin, also known as adriamycin, cyclophosphamide, also known as Cytoxan, 5-fluorouracil, also known as 5-FU, paclitaxel, also known as Taxol, docetaxel, also known as Taxotere, and epirubicin, also known as Elence. These drugs are often used in combinations for better effect rather than used singly. 4 of the most frequently used chemotherapy combinations for adjunctive therapy are AC, adriamycin and cyclophosphamide, CMF, cyclophosphamide, methotrexate, and fluorouracil, CAF, cyclophosphamide, adriamycin, and fluorouracil, and AC followed by T, that is adriamycin cytoxan followed by Taxol. Several of these combinations have been developed by clinical research conducted in the United States and worldwide. These combinations are continually being modified and tested in ongoing research protocols seeking to improve efficacy and reduce toxicity. Your doctor will recommend what is best for you and will also discuss with you your eligibility for any research protocols. We are actively engaged in clinical research studies which are testing new combinations of standard drugs as well as new drugs. We work with the National Cancer Institute as well as with pharmaceutical companies. Chemotherapy has many side effects. Some of the most common are hair loss, nausea and vomiting, and the lowering of your blood counts. Chemotherapy may induce premature menopause in women who are regularly menstruating. This effect may be temporary or permanent. Before you start treatment, your doctor and nurse will review these side effects in detail with you and explain how to cope with these toxicities. There are many ways to treat a patient with these side effects. Hormonal therapy works in women whose breast cancer is estrogen receptor positive. It prevents the estrogens made in the woman's body from stimulating cancer cell growth. The most common hormone therapy for early-stage breast cancer is the drug tamoxifen. Tamoxifen occupies the breast cancer cell's estrogen receptors, blocking estrogen's action on the cancer cells. It is used in women whose tumors are estrogen or progesterone receptor positive. Women with early-stage breast cancer who take tamoxifen have an average of 35% proportional increase in their chances of surviving 5 years after diagnosis. This varies according to their age and menopausal status. Tamoxifen is a pill taken daily for 5 years. The most common side effects are hot flashes and abnormal secretions from the vagina. Tamoxifen has 3 long-term, more serious side effects. It slightly increases the chance of developing cancer of the uterus and accelerates cataract formation. It also increases risk for blood clots in women over 50. Tamoxifen also has health benefits. For example, it lowers bad cholesterol levels, it supports bone growth, thereby lowering the risk of osteoporosis, and tamoxifen significantly lowers your risk of developing breast cancer in your unaffected breast. You can discuss tamoxifen with your physician to see if it will be beneficial for you. There are other hormone therapies for early-stage breast cancer in postmenopausal women, such as aromatase inhibitors, examples of which are Arimidex, Femara, and Aromasin. They are not recommended for women who are premenopausal. Hormonal treatment in women who are still menstruating may also involve interruption of ovarian function by medical or surgical methods in addition to tamoxifen. Breast cancer, that is HER2-neu positive, may respond to Herceptin. Currently, in early-stage breast cancer, Herceptin is only used as part of a clinical trial and is not a standard treatment.